Yeah. Good evening, everyone. I'm Dr. Pranjali Gadgil. I'm a breast cancer surgeon and breast disease specialist at Jupiter Hospital. I run the breast clinic here at Jupiter Hospital, and at the clinic, we actually see patients with a whole bunch of breast problems ranging from cysts, fibroadenomas, breastfeeding related issues, developmental breast issues, cosmetic breast concerns related to breast size. We obviously see breast cancer patients who have had breast cancer in the past and need surveillance and advice on life after breast cancer. We do see male patients with cosmetic concerns like gynecomastia as well as male breast cancer. But today, the specific topic we're going to focus on is breast cancer and myths related to breast cancer. And the reason to pick this topic was it's really heartbreaking to see that in spite of the advanced surgical skills we have, the modern access to modern medicines that patients see, that cancer outcomes that I see in India are just as not as good as what we were seeing in the US. So in spite of having technology that's almost at par. So what is the reason for this? And if you think about it, women often come to us very late in the disease stage, and this is probably because of a lot of misconceptions and misunderstandings that we have about breast cancer as a disease. And so the goal for today's talk is basically to dispel some of these myths, to advise you on what are the good and safe breast health practices you need to adopt, and how would you guide a friend or family dealing with a breast problem, so if they were to ever breast cancer, they're going to come out of it completely cured and stay safe. So let's come to the first set of myths. And the first set of myths that pertain to breast cancer revolve around who gets breast cancer. And everybody thinks, well, somebody else gets breast cancer, right? Because we never think it's something that's going to happen to us. So one of the things to remember is breast cancer really can happen to absolutely anybody. So nobody is really immune to breast cancer. It's not because you did anything wrong or you ate anything wrong or somebody gave it to you. It's just an accident happening at a cell level, and so it can happen to anybody. So the first myth that I'm going to talk about is, one common thing I hear is, I'm only 30, so I don't have to worry about breast cancer, right? So this is really not true, because there is something called as young breast cancer that can affect women who are in their 20s and 30s. Most breast cancers happen to women in the 40s and 50s. But yes, there is a fraction of women who will develop it in younger age groups. And this is really important for doctors to know as well, because when a young woman presents with a breast lump or any other complaint, very often we find that somebody reassures her that, it must be a fibroadenoma, or it must be related to recent, pregnancy and breastfeeding. And so oftentimes when these women come to us, they come to us at a late stage. So it's important to remember that yes, young women can also develop breast cancer. The second is older women can also get breast cancer. So oftentimes I'll get a woman who will say, I go for regular breast checks, but my mother, she's almost 70, she's had a hysterectomy, she's been postmenopausal for over 2 decades. I don't think she's at risk of breast cancer, is she? And the truth is, yes, she is also at risk of breast cancer. In fact, risk of breast cancer increases as your age advances, because naturally, as the body's repair mechanisms get a little weaker and more defective, your risk of cancer actually increases. So, and sometimes I have these, very young 70, 80-year-olds who are living a very fit and active lifestyle. And, picking up a cancer early in these women is actually going to help them live a better quality of life. So yes, there's no age at which you need to stop doing these preventive breast exams. The third is, another common myth is, I don't have any family history, so I don't have to worry about breast cancer. And this is a very, very common myth. So women, who feel a breast lump will say, nobody in my family has had any type of cancer. There's absolutely no reason this should be breast cancer. This is another big myth, because 85% of breast cancers are actually going to be found in women who have absolutely no family history. So only 5 to 10% of patients actually have genetic type of breast cancer, where there is a gene mutation that you inherit from your parents. You are at risk of passing it down to your children. And we will address genetic testing and hereditary breast cancer as a separate session someday. But it's important for you to remember that just because you don't have a family history doesn't mean you're immune to breast cancer. Another thing that women think is, well, I've breastfed all my children, so I don't think I'm at risk of breast cancer. Now, breastfeeding does lower your risk of breast cancer, but it does not protect you 100% from breast cancer. And this is like a risk reduction, right? So if you have, let's say, we group this audience into women who've had pregnancies and have breastfed, and we have women also who've not had a pregnancy perhaps until they're over the age of 30, women who've not had an opportunity to breastfeed. We're going to see a fewer more cancers in the group that has not had pregnancies and breastfeeding. But that doesn't mean that we're going to see no cancers in the group that has done breastfeeding. So this has to be looked at in risk context. So it doesn't confer immunity 100% to you just because you breastfed. Now, another thing I often hear is, well, I don't smoke, I don't drink, I lead a pretty healthy lifestyle, I eat well. So, why should I get breast cancer? And I see this very often happen in my young breast cancer patients who are actually leading a very healthy lifestyle. So this is, like I said, this is an unfortunate accident that happens at a cell level. You should continue to practice these, good health behaviors, because if you regularly exercise, up half an hour a day for 5 days a week, you are probably going to have a 20% lower risk of having breast cancer. So it's a great investment in your health to actually go ahead and exercise. But again, it doesn't make you immune to cancer. So as you've seen, breast cancer really can happen to anybody. As we said in the introduction, it can happen to men as well. And men, again, men don't think they can get breast cancer, and so when they do get it, they often come at a late stage when it's already spread to lymph nodes and other parts of the body. So it's important to remember anybody can get breast cancer. So I'm not trying to scare you, I'm just saying, don't live in an imaginary bubble of, okay, you're immune to it, because nobody is. Now, the second set of myths we're going to talk about is, what does breast cancer feel like? So, the biggest thing is women will often say, well, I have a lump, it doesn't hurt, so it can't be cancer. Well, this is the biggest myth there is. Most breast cancers are absolutely painless. And this is really important to know, because often, I see women who say, well, I've had this lump for 6 months now. And I'm like, did you show anybody? No, I chatted about it with my husband. He said, well, does it bother you? Is it painful? No. So then they just assumed that it can't be anything serious, because something like cancer should hurt you or bother you, and it really doesn't when it's early stage. So women think often also that, if I have cancer, I should be really sick. This is another myth, because in early stage breast cancer, you're not going to be sick at all. You're just going to have a lump which is going to have cancer cells, and the rest of your body is going to continue to function just fine. So it's only when cancer spreads to other parts of the body, it spreads to your lungs or brain or liver or something like that, that's when it's going to overwhelm your body, and that's when your body is going to give you signals like loss of appetite or loss of weight. Until then, you're going to be just fine. So just because you have a concern and you don't have these symptoms, please don't neglect it, because now is the time to actually get this addressed in a timely fashion and get a breast cancer cured. The third symptom is, women understand that a lump can be a sign of cancer, but oftentimes they'll say, well, I'm not quite feeling a lump, I'm feeling something vague. So it's important to know that breast cancer is not always a lump. For example, I'll tell you, a patient recently came and she said, well, I have this, I felt a 10 centimeter tumor, and it was a huge tumor. And I said, well, how long have you felt this lump? And she said, well, I never actually felt a lump. Okay, but you must have felt something, because this is 10 centimeters today. So she said, well, I felt a little thickening in one area of the breast. One area just felt a little denser, harder compared to the rest of my breast. Then I realized that the skin above it started looking more thick, started looking red. Then I applied some creams. Then I noticed that some of the veins there got bigger. Then I noticed a little scrape on it or a wound on it. Then I did some dressings for it. So in all this, women just keep wasting time because they look at all these concerns they have, symptoms they have, and keep telling themselves that it's not cancer. So don't try to diagnose yourself at home. Breast cancer is not always a lump. Sometimes it can feel like a vague density, just an area of irregularity in one area that doesn't quite feel like the other side. Sometimes you may notice things like nipple discharge, like bloody nipple discharge or watery discharge. That can be a sign of breast cancer. Changes in the skin, like unexplained redness, thickening, a rash around the nipple. You may sometimes even feel a lump in the armpit because breast cancer tends to spread to lymph nodes in the armpit. So every so often I'll get a woman who feels a lump in the armpit and the biopsy shows it's from the breast cancer, but she may not feel the lump in the breast at all. So it's important to know that even a lump in the armpit needs to be seen by a breast specialist. The third thing is, it's not quite a myth, but it's a dangerous health behavior. Like women will often attribute a new breast problem to an old one that they're familiar with. For example, if I'm a 50-year-old woman, I'll say, you know what, I feel this lump, but I know that from my 20s and 30s, I've had cysts, I've had fibroadenomas, so this is probably the same thing. And this is a very dangerous practice because every new breast lump needs to be looked at afresh with a fresh set of eyes, a fresh set of investigations, and needs to be sorted out correctly and completely. So never assume, don't try to diagnose yourself at home, don't imagine what it is, get yourself seen by a specialist. So the third set of myths revolves around investigations that are to be done. And when it comes to breast and breast health and breast cancer, there are a whole bunch of investigations we hear about: mammography, ultrasound, sonography, sonomammography, and women are just very confused about what they should do when. So as a golden rule, remember, if you're a healthy woman, after the age of 20, once a month, start doing breast self-exams. This is not hard to do. Just when you're in the shower once a month, get used to feeling what your normal breast feels like. So that way you get used to feeling what is normal for you. If something changes from this baseline, then you know that you have to come in and see somebody. So that's the whole goal about self-breast exams. Do this once a month after the age of 20. After the age of 30, once a year, get your doctor to perform a clinical breast exam. This doesn't involve any investigations. It's a simple physical breast exam done by your doctor. It could be any doctor. It could be your gynecologist. It could be your family physician. Just make sure when they do your annual check, you get a breast exam done as well. And if they feel something odd, they will guide you to the right investigation. So typically, if you're a doctor, if your patient is less than 40, you're going to start with an ultrasound of the breast. If your patient is over 40, you may start with a mammogram of the breast and do an ultrasound as and when needed after a mammogram. Now, the third rule is for mammography to be done after the age of 40 once a year. So after the age of 40, once a year, do annual mammography. Now, when it comes to mammography, the first myth is, well, if I'm fine and I don't have any concerns, why should I do mammography at all? So the mammography we're talking about here is not for a diagnosis. This is screening mammography. This is a type of mammogram done on healthy women to give them the opportunity to pick up any breast concern like a cancer early, at an early stage. So think about it like, if you wanted to prevent a heart attack, you would check your lipids, you would check your sugar levels. You wouldn't wait to get a heart attack and then go check your lipid levels. So this is kind of like that. So when you do mammography year over year, you look at changes over time. And so if I saw something today that wasn't there in the last few mammograms, I know this is a new growth and it needs to be attended to. And I may ask you to do certain additional maybe images. I may ask you to do an ultrasound. I may ask you to do a biopsy, whatever it takes to sort that out. But that's the whole goal of mammography. So, women often misunderstand this. So when I get a woman who's come with a 5-centimeter lump, often she will come with a mammogram and say, okay, I have a lump, I feel it. The mammogram also shows it. And I ask her, well, have you had a mammogram done before this? And she says, yeah, well, I did one 5-6 years ago. I did it for two years maybe. And then they were fine. So then I stopped doing it. Well, that's where you've missed the opportunity, right? Because if you had continued to do a mammogram once a year, this lump that we are feeling as a 5-centimeter lump today, we might have felt this maybe 2 years ago. I mean, we would have picked it up on a mammogram 2 years ago before you could feel it by hand, before I could feel it by hand, and we might have picked it up when it was perhaps 1 centimeter in size. It was stage 1 at the time, and you had a 95% or more chance of getting cured from this cancer because it was picked up so early. So that's the whole point of doing mammography, and women are really afraid. Another myth I hear about mammography is, oh, it's painful, it's got radiation, let me just go do an ultrasound instead. Well, no, because mammography is going to pick up things that an ultrasound is going to miss. The one thing that I will say though is, we have a whole bunch of places that are doing mammography around us today, but very few places which are doing enough numbers in high volumes to be able to do it well and correctly. So it's important to go to a good mammography center where the technician is experienced, so that there is no reason the mammography experience should be really uncomfortable or painful. You should develop enough of a comfort level that you would want to go there year over year and get your mammograms done in a regular, sincere manner. So the next problem when it comes to diagnostics is when you do get a mammogram, women often get confused about what to do. And this also pertains to doctors. So let's say a mammogram shows something like calcifications. Firstly, women get very confused that, is this calcium because of I'm eating a lot of calcium in my diet? No, that's not true. This calcium has nothing to do with your blood levels of calcium. This calcium is just a hint about something going wrong with cells that are now accumulating this calcium and giving us a clue that this area needs to be looked at in more detail. Now, a presence of these calcifications on a mammogram doesn't always mean that this is cancer. So not all calcifications are going to represent cancer, but interpretation of mammography really needs a lot of skill and experience. So some patients are going to have calcifications which are completely benign. Some are going to have suspicious calcifications which need to be biopsied today. And some are going to have calcifications which need to be observed at shorter intervals. And this is not like a hemogram where, okay, your hemoglobin is either normal or it's low. This takes a lot of experience in interpretation. So you do need to go to either a breast imaging specialist or a breast surgeon to sort out what the implications of your mammogram actually are. So don't try to interpret your mammograms at home. The next thing when it comes to diagnostics is misconceptions around biopsy. So if a woman has been advised to do a biopsy, usually what we recommend is a needle biopsy as the first step. And women often believe that, if you do a biopsy, this needle might disturb my tumor and it's going to spread everywhere else in my body. So think about this, like if actually me doing a biopsy caused your tumor to spread, I wouldn't actually be doing it, right? So, but it's not about what I think or what I feel. This has been studied in a large number of studies that have looked at this issue, that, these cells which may get displaced are not viable cells that implant anywhere. So it's perfectly safe to do a biopsy. In fact, we know that women who have a diagnosis based on a needle biopsy always do better than women who directly go in for surgery and a surgical excision for a biopsy. So don't be scared of a biopsy. It's a 10-15 minute OPD based procedure. It's done under local anesthesia. You don't have to be fasting. You can walk out of there. It's like getting a little injection in the breast. It's not supposed to be painful. And it's the most sure shot way of getting a diagnosis of what your breast problem actually is. The next point is, women will often ask their doctors, well, if it's a breast lump, why worry about a biopsy? Just take it out. And then we'll figure out what it is. So that it doesn't matter what it is, I just want it out. Well, this is a very common ask that actually comes from the patients, but I really hope some doctors are also listening here. Really don't do these excisional biopsies. Don't encourage your patients to undergo unnecessary surgery for a diagnosis. And this is really important for multiple reasons. One, there are a lot of things in the breast that will present as masses that absolutely do not need surgery. Some of these may be simple cysts, some of these may be small fibroadenomas, and these can be observed safely if we know if the diagnosis is done right. Secondly, there are a lot of benign conditions which respond beautifully to medical treatments. So there's breast tuberculosis, there's granulomatous mastitis. These are treated with medicines, and we don't need to do surgery for this. In fact, surgery can sometimes mess up the subsequent treatment of these conditions. Thirdly, if it's cancer and you just take out a lump and that's how you figure out that it's cancer, this really sets a patient back, because now they're going to need a second operation, because a cancer operation doesn't simply involve taking a lump out. We have to do a surgery to make sure that margins are clean, that the lymph nodes are sampled. So it's a whole lot more than simply taking a lump out. So now your patient has to undergo a second procedure. There are some patients where we may give them certain medical treatments to shrink down the tumor before we actually operate. So if you've already done a surgery, that kind of messes up this plan as well. Thirdly, if a scar and an incision is made in the wrong place, and we would have had a great opportunity to do a nice cosmetic operation for this patient, now the aesthetic outcome becomes a little bit more difficult to accomplish, because the scar is placed in the wrong place to accomplish some of these refined techniques that we do, called skin sparing procedures and other oncoplastic procedures for where the scars are hidden instead of being visible. So don't unnecessarily take out breast lumps for a diagnosis. Surgery should be done, one, only if it's necessary, and two, the right operation should be done for the right reasons and done correctly and completely in the first go. So that's about diagnostics, and hopefully this helps you clarify some of these issues. And the best thing is, let a specialist guide you about what diagnostic test to do when. If you're confused about what test to do, just come into the breast clinic and we'll tell you what tests you need to undergo, if any. So the fourth set of myths, they pertain to treatments. And women really don't, if they think that they have a cancer, sometimes they just don't come in to get checked, because they think, well, if I have cancer, I'm going to have to undergo surgery and my breast is going to be removed. That is absolutely no longer necessary and no longer true. So in the majority of cancers, we're able to preserve the breast, reshape the rest of the breast, and achieve a beautiful cosmetic outcome, preserving most of the breast tissue. This is something called as oncoplastic surgery. There is no need to remove the breast in case of small tumors. In larger tumors, we are often able to shrink down the tumor by giving you certain medical treatments ahead of time before surgery, and we can achieve a much better result with a smaller surgery doing some of these practices. Thirdly, even in cases where we do have to remove the breast, we're doing what we call as immediate reconstructions. In these cases, we're often able to preserve the whole skin envelope with the nipple, areola, everything left in place. And then we make a hidden scar, we remove the breast gland from underneath the skin envelope, and we replace it in the same setting with either an implant or your own tissue. That own tissue may come from either your belly fat or muscle from your back or wherever, depending on what my plastic surgery colleagues will do. And hopefully Dr. Swapna Atole, my plastic surgeon, and I will do another session for you on specifically on some of these cosmetic and reconstructive sessions. But know that, if I showed you pictures of some of these women who've had mastectomies and reconstructions, you may not even be able to tell that they've had any kind of surgery done at all. So don't think that breast cancer means you're going to have some mutilating surgery and removal of the breast in each case. The next common myth is, well, I'm afraid of these toxic allopathic treatments, so I'm going to just take homeopathic and Ayurvedic treatments to get better. No, you're not, because it doesn't work. So I do have a lot of great doctor friends who are allopathic and homeopathic doctors, but they know that when it comes to breast cancer, modern medicine is the way to go. And there is no war of the pathies here. It's not allopathy versus naturopathy versus some other pathy. Really, if you think about a drug like vincristine, it originates from a plant. It comes from your sadafuli or vinca flower. So that doesn't mean we start asking you to eat flowers when you have cancer. What we do is we've extracted and identified what the active anti-cancer alkaloid in that plant is. We've packaged it into a drug that is easy to take. We've measured exactly in so many 100 studies what dose it should be given in to be effective, what dose is going to be tolerated for your body size, and that's how we're dispensing this drug to you in modern medicine or modern oncology. So it is no longer this pathy versus that pathy. You should only take treatments that actually work, which you're going to find in modern medicine with an oncologist. The third common myth is, well, oftentimes you've heard of a case of breast cancer and you say, well, somebody I knew had this type of surgery, then they had chemotherapy, then they had this outcome, so the same thing's going to happen to me. No, it's not. Because not every breast cancer is the same. Every tumor is different, everybody's response to the tumor is different, everybody's stage is different. The tumor genetics is different, your genetics is different, and treatments are going to be based on a combination of all these factors taken into consideration. And they're also not going to be done based on guesswork about what I feel I should do with this. There are very well done studies. Over 100,000 of patients have been put through hundreds of clinical studies, and we know what works and we know what doesn't work, and that's the basis of forming that's what goes into forming guidelines and evidence with which we treat breast cancer. So no breast cancer is the same. So do not be misguided or misled by somebody else's experience, because your experience going through it may be completely different. Another common myth is, if I've had surgery for an early breast cancer, I really don't need to do any additional treatments, do I? Because the tumor is no longer in my body. This is another myth and misconception. You do need to know that there is disease that we see, that we remove at the time of surgery, but there is circulating cells which may cause recurrences later, and that's the component that we're fighting with chemotherapy, with hormone therapy, with other biologic therapies as the case may be. And we want that this tumor not come back either in the breast or anywhere else in the body. And for it to not come back in and around the breast area, we also do radiation treatments. And patients often are confused about radiation because they think, is it going to burn? Is it going to be painful? Is it going to hurt? No, breast radiation is actually tolerated very well. So if you've been advised to go through with it, please go ahead and complete all advised treatments, because they're only done if they work, they're only done if they benefit you. So not every breast cancer patient needs chemotherapy. There are a whole bunch of patients that we study the genetic makeup and we say, you know what, this particular tumor does not need chemotherapy. You may require hormone therapy alone. But these are not assumptions you should make. You should consult your oncologist and let them guide you about what are the right treatments that you need to go through. So those are some of the topics about treatments. So to conclude, don't believe everything that you hear. If you have a breast concern, don't try to diagnose yourself at home. Don't assume anything. Preventive breast practices, I already told you, after the age of 20, self-exam once a month. After the age of 30, exam by a doctor once a year. After the age of 40, mammography done sincerely every year. If you have a breast concern, see a breast specialist. If you have breast cancer, know that it is completely curable with complete and correct treatment. So make sure you follow the advice of your oncologist. If you're a patient who's had breast cancer in the past, know that you need to stay in lifelong follow-up with your oncologist, undergo the regular tests they advise you to undergo, so that if at all you were to ever have a recurrence, you pick that up early and you catch it early and you come out of the other end safe and doing well. So with this, I'm going to conclude this session, and hopefully we can do some more sessions specifically on topics like mammography, genetic testing, young breast cancer survivorship, and we'll keep you posted about as and when we do some of these sessions. So thanks a lot for joining, and we have a couple of comments here. Let me see if we can take some questions. Here we go. So do women need to undergo specific markers like CEA, CA125, and tumor markers as a blood test to pick up cancer early? So that's an excellent question, actually. So these tumor markers have specific role in following specific cancers. These are not used as screening tests in healthy patients. So just because some package offers a whole bunch of tumor markers, don't do it, because you will not know how to utilize that information. These need to be advised only under the guidance of an oncologist, and we use these typically to follow patients who've had previous cancers to see if any marker is rising in their blood once they've been treated. So that's a great question. What else do we have here? Hey, there's a whole bunch of you all who have joined. Looks excited about the response here. So what is the percentage of biopsy being false negative? Wow, great question here again. So the older type of biopsy that we used to do was called FNAC, and the false negative rate of that was actually very high. It could be as high as 40-60% depending on what studies you look at. Because that older test, what it used to do was just pick up a few cells, and then it would tell you either it's cancer or it's not cancer, or it just looks a little bit weird, or atypical cells, or it's an inadequate sample because it's just picked up some blood or fat. So FNACs have pretty much become outdated when it comes to breast biopsy. What we do now is called as a core needle biopsy. So we pick up tissue which is actually a piece of the lump. So this is histopathology diagnosis which you would have got if you had actually removed the lump. The pathologist would have taken microsections of it, looked at it under the microscope. So instead we are giving them a piece to look at under the microscope without actually doing the surgery. So the biopsy results are far more accurate. Now, when you talk about false negatives, can they happen in a core biopsy? Yes. But the way to protect yourself from those, and it happens in a much smaller percentage of cases. So it can happen in 5 to 10% of cases. Over 90% of times your core biopsy result is going to be accurate. But how do you protect yourself from even that small number? And this is something called as radiopathological concordance. It's a complicated term, but what it essentially means that 2 and 2 has to be equal to 4. So for example, if I feel a lump and it looks suspicious, and I'm looking at your mammogram and to me that looks suspicious, and you come with a biopsy that says, hey, this is benign or it's normal breast tissue, and that tells me something's not adding up, because 2 and 2 is not equal to 4 here in this equation. So in this case, I'm going to say, you know what, let's look at your biopsy blocks a little bit more in detail, or let's rebiopsy. Or if we still can't sort it out, in that case, I might advise you on surgery. So that's how we protect you from the false negative impacts of needle biopsy. All right. All right, so I think those were all the questions that we had. Thank you so much for joining us, and hopefully you'll join us again on some of these other sessions that we do in the future. Thanks a lot.